You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for September 17th, 2021. This is a third ESC wrap-up show. Today, cardiac arrest care, Finerenone, carotids, medicines post-TAVI, and today we will also hear lessons about less is more, and the new treatment not always being as good as the tried and true. First, COVID, of course. The big news this week is the debate on boosters. This is a masterclass of evidence-based medicine. FDA will discuss the evidence in a meeting today. The agency did strike a cautious tone and release documents this week. First topic is cardiac arrest care. Now, I don't know how things are where you are, but in my zip code, the cardiac cath lab carries a sort of mythical, lofty status of a place where sick patients should go to get better. And one of the main reasons people suffer cardiac arrest is, of course, myocardial ischemia, especially acute ischemia. When there is ST segment elevation after a resuscitated arrest, everybody agrees that the cath lab activation for urgent revascularization is warranted. But what about when there is not ST segment elevation? In 2019, the COACT trial, C-O-A-C-T trial, studied immediate angiography versus delayed angiography in patients with cardiac arrest who did not have a STEMI. Immediate angiography did not significantly reduce the primary outcome of overall survival at 90 days. But the Dutch-led COACT trial included only patients with a shockable rhythm. The Tomahawk trial, presented at ESC and published in New England Journal of Medicine last month, was led by a team from Leipzig, Germany, studied the strategies of immediate versus delayed coronary angiography in 550 patients with successfully resuscitated out-of-hospital cardiac arrest, and these patients did not have a STEMI. First author, Stefan Desch. 30 days, 54% in the immediate angiography group and 46% in the delayed angiography group had died. The hazard ratio was 1.28, and the confidence intervals went from 1.0 to 1.63, p-value 0.06. The composite of death or severe neurologic deficit occurred more frequently in the immediate angiography group, 64% versus 55%, and the relative risk here was 1.16, and again, confidence intervals 1 to 1.34. The authors concluded that the strategy of performing immediate angiography provided no benefit over delayed or selective strategy with respect to the 30-day risk of death from any cause. So some comments. First, the specifics. And not only wasn't the immediate strategy better, death was 20% higher with the near entirety of the confidence interval greater than 1, indicating a high probability of harm of this strategy. The upper bound of the confidence interval allows for a 63% higher death rate with early angiography. What's more, the composite of death or neuro outcomes was also 16% worse, and again, the confidence intervals were almost all essentially above 1. As the authors point out, this may be a chance finding, but it also could be that immediate angiography distracts or delays from early diagnosis and treatment of other conditions that are important for these patients. The authors also spend many words in the manuscript explaining why immediate angiography didn't work. But I would say that given the strong concordance of these two large RCTs, both looking at the same strategy in similar patients, and both of which show no benefit, and Tomahawk trending towards harm, it does not matter why the immediate strategy did not work. I lead the podcast with Tomahawk because I love these sorts of strategy trials. Now, it won't get the attention of a drug or device trial or a positive trial, but well-done studies like this teach us so much. Not just that immediate angiography doesn't help this cohort of patients, but far more important, the German and Dutch trialists have shown us that accepted strategies of care can and should be tested, and that notion could not be more relevant to our current situation with the pandemic. All right, next topic, the new drug Finerenone and cardiovascular outcomes. Now, this summer, FDA approved the special mineralocorticoid receptor blocker Finerenone for the prevention of CKD in patients who have type 2 diabetes. Finerenone is special because it is nonsteroidal and will not have the anti-androgen effects of, say, spironolactone. Now, this approval was based on the Fidelio DKD trial, which randomized about 5,700 patients with diabetes and CKD to Finerenone or placebo and found a highly significant 18% lower risk of CKD progression with Finerenone. That trial also included some cardiovascular outcomes as key secondary outcomes. And Finerenone reduced the risk of the composite cardiovascular outcome compared with placebo. The hazard ratio in that trial was 0.86, so a 14% reduction, and it was significant. There was no significant interaction between patients with and without baseline cardiovascular disease. Now, in this trial, 3 of the 4 components of the composite endpoint trended lower with Finerenone. CV death was lower, MI was lower, heart failure hospitalizations were lower, stroke were similar. At ESC, we learned the results of the cardiovascular outcomes trial called Figaro DKD. This was sort of a sister trial of Finerenone versus placebo. About 7,200 patients with CKD and type 2 diabetes were randomized again. Finerenone versus placebo. Primary outcome was a composite of CV death, MI, stroke, and heart failure hospitalizations. Similar to the Fidelio DKD trial, to be included in Figaro, patients had to have urinary albumin. In Figaro, lower levels of urinary albumin were allowed. Okay, let's get to the results. After follow-up of 3.5 years, a primary outcome event occurred in 12.4% in the Finerenone group, 14.2% in the placebo. The 1.8% absolute risk reduction translated to a hazard ratio of 0.87. So a 13% reduction, and the 95% confidence intervals range from 0.76 to 0.98, roughly meaning that the benefit could have been as great as 24% or as little as 2%. The p-value was 0.03, and so if Finerenone had no effect, the chance of finding this result or something more extreme was about 1 in 33. So this is a positive trial, right? Let's get on the Finerenone bandwagon because it reduces cardiac events in patients with type 2 diabetes. Not so fast here. The first thing to do with these composite outcomes is to look at the components of the composite outcome. You have some strong ones here, CV death and stroke, and some not so strong ones like MI and especially heart failure hospitalizations. So let's look at them. CV death, 5.3 versus 5.8%, so that's not significant. MI, 2.8% in both, so obviously the same. Stroke, 2.9 versus 3.0, obviously non-significant. Heart failure hospitalizations, 3.2 versus 4.4. So that's where the driving force came from for the composite endpoint. It was all heart failure hospitalizations, and it ended up being a 29% statistically significant reduction in heart failure hospitalizations. But as we went over the last 2 podcasts in the discussion of the Emperor Preserve trial, if you are going to say heart failure hospitalization is an important endpoint, it better represent a big chunk of total hospitalizations. Well, if you look at Figure 2 in the New England Journal paper of Figaro, you will see that total hospitalizations or all-cause hospitalizations were 42.7 in the Finerenone arm and 43.8 in a placebo arm, a hazard ratio a measly 0.97 and not significant. And that is because in this population of 64-year-old, mostly white male patients, heart failure hospitalization represents just 8% of total hospitalizations. Pause there for a moment. How can heart failure hospitalizations be an important endpoint when it represents less than 10% of total hospitalizations? The answer is it can't. Now, this drug will surely be costly. It's new. It'll be heavily marketed, and the nonsteroidal nature is nice, but this data is totally unconvincing as a CV outcomes drug. There's no difference in CV death, MI, or stroke, and the heart failure hospitalization endpoint is just not a major outcome in these patients. As for the first secondary composite renal outcome of sustained decrease of at least 40% in GFR, or death from renal causes or kidney failure, there was a 13% reduction with Finerenone that just missed statistical significance. Now, as for adverse outcomes, overall there were no differences, but hyperkalemia was seen in 10.8% of patients versus 5.3% in placebo. So a pretty big difference. So putting it all together, Finerenone seems nice because there'll likely be better tolerability and maybe less hyperkalemia, maybe. Both trials showed trends towards improved renal outcomes. And both trials shows slightly better, numerically better CV improvements, though in patients with less severe kidney disease. In Figaro, the CV benefits were driven by a very weak endpoint of heart failure hospitalizations. Note, I am not saying that heart failure hospitalizations is always a weak endpoint. It is only a weak endpoint when it represents a tiny proportion of total hospitalizations. Now, another problem for translation of these trials to the current situation is that only 7% of enrolled patients, these are diabetic patients with chronic kidney disease, were on SGLT2 inhibition. So the question remains, how much added benefit will Finerenone be when you add to a drug like SGLT2 inhibitors who have known benefit? We now know that diabetes and CKD are probably the sweet spot for SGLT2 inhibitor use. Ultimately, the use of Finerenone will come down to value. If Finerenone costs the same as spironolactone, then fine, it's a no-brainer, go with it. But it's not going to cost that little, it will cost a lot. And while the renal and CV outcomes are evident, they are decidedly modest when applied on an individual patient level. Third topic today is carotid stenting versus carotid endarterectomy, the ACST2 trial. At ESC, investigators from the UK, Professor Alison Halliday, who's a PI, presented the ACST2 RCT of carotid stenting versus carotid endarterectomy in patients with asymptomatic carotid disease. Asymptomatic carotid disease, and these patients were felt to require intervention. Now note that the verb require is doing a lot of work, and I will return to that verb in a discussion. Lancet published a paper, two primary outcomes. First, peri-procedural risk, defined as MI, stroke, or death within 30 days. And the second outcome, long-term rates of disabling or fatal stroke during follow-up. The trial started 13 years ago in 2008, randomized about 3,600 patients from 130 centers, so roughly about 1,800 patients in each group. Peri-procedural outcomes first. 3.6% stroke with stent, carotid stent, 2.4% in the carotid endarterectomy group. This was a p-value of 0.06. MIs, 5 versus 12. Death, 2 in each group. And now, finally, if you look at just a combination of death, MI, or any stroke, it was 3.9% in carotid stenting, 3.2% in carotid endarterectomy, and the p-value was 0.26, so not statistically significant difference. The investigators did note an increase in non-disabling stroke in the first 30 days. That was 2.7% versus 1.6%, and that p-value was significant. The total rate of any non-procedural stroke was 5.2% for carotid stenting, 4.5% for carotid endarterectomy, and the total rate of procedural death or any stroke total was 8.6% for carotid stenting, 7.0% after carotid endarterectomy, so slightly worse for carotid artery stenting, but the p-value was 0.09. So the top-line results of the trial were that the results are technically similar. The authors write, quote, "Our main finding was that the effects of the two procedures on disabling or fatal events are approximately equal in terms of procedural hazards." And what I would also add to that is that no patient who had a carotid stent had a cranial nerve injury, whereas 5% in the carotid endarterectomy group had it at 1 month. 3 main summary comments. First, I love the author's very first sentence of the discussion section in this paper. Quote, "This trial does not address the question of whether or when a carotid intervention would be appropriate. There remains a great debate, my friends, on whether a patient with no symptoms who has a carotid lesion should have an intervention. The gamble, of course, is that the cumulative rate of ipsilateral stroke reduction from fixing the blockage in that carotid over and above medical therapy will be greater than the upfront risk of the procedure. Now, when you look at the as-treated analysis, that is, patients who actually got each procedure, carotid artery stenting has a greater than 3% risk of procedural stroke or death and a nearly 3% risk in the carotid endarterectomy arm. To me, that 3% initial risk seems like a big hurdle. This is quite like the issue with Watchman or any other preventive procedure or surgery. There's a pretty large risk up front. So if the gains from the procedure are great enough, and if the patient lives long enough, there may be a probabilistic benefit. But without a medical arm in this trial, we just don't know. Sadly, we don't know. Now, the authors cite previous data suggesting that carotid endarterectomy may have the risk of stroke relative to medical therapy. The problem, of course, is that these studies were done many years ago, some decades ago. Medical therapy, of course, has improved and the rates of cardiovascular events have declined. Further, as we talked about in an interview I did with ACST2 author Richard Bulbulia, the approach to asymptomatic carotid disease varies a lot by country. In some countries, it is common for asymptomatic patients to have carotid interventions, but in other countries, the rate of carotid interventions in asymptomatic patients is nearly 0. My second comment here is that while the rates were close, there does seem to be a numerically higher stroke rates in the stent arm, both peri-procedurally and later. In the supplement, I found an interesting figure, and the figure that caught my eye was the rate of procedural death, procedural stroke, or non-procedural ipsilateral stroke. Ipsilateral stroke is important because the procedure should have minimal effect on contralateral stroke. Now here, the rate was 5.3% versus 3.6% in favor of carotid endarterectomy, almost 2% higher rate of events in the stent arm. But of course, carotid artery stenting has fewer MIs, no cranial nerve injuries, and shorter hospital stays. It seems to me that this sort of information can be incorporated into a decision support tool, and with the guidance of a wise clinician who's skilled in both types of procedures, decisions could be individualized based on a patient's unique features and goals for care. And related to that comment, though, is to translate this evidence at bedside, you have to have some reassurance that performance of either procedure, the carotid stent or the carotid endarterectomy, in the real world would be similar to this carefully selected centers in these trials. Now, given the improvement in medical therapy, which leads to lower baseline rates of stroke, any slight increase in upfront harm will push against the probability benefit. One final issue is, I wonder whether technology might help adjudicate which of these bad lesions may benefit more from revascularization. I mean, things like transcranial Doppler, intraplaque hemorrhage seen on MRI, or reduced cerebral blood flow reserve, these sorts of things. Would that help guide us to the lesions that most would benefit from revascularization? Final topic today is protection after transcatheter aortic valve replacement when AFib is present. Let's start with 4 baseline facts. First, AFib and aortic stenosis are common conditions that go together in older patients. Patients who have AFib benefit from anticoagulation. DOACs, direct-acting oral anticoagulants, beat warfarin in trials of patients with AFib, and patients who have TAVI require some degree of antithrombotic medicines after the procedure. Since DOACs appear useful against warfarin, how will they do after TAVI? Trouble is, DOACs haven't looked that good in post-TAVR patients without AFib. For instance, as background here, the Galileo trial compared rivaroxaban 10 milligrams versus aspirin post-TAVI, and rivaroxaban had a higher risk of death or first thromboembolic event. And another trial, Atlantis, apixaban versus warfarin or aspirin post-TAVI. In the control arm of this trial, if there was an indication for anticoagulation, the patients got warfarin, if not aspirin. Here, there was no significant difference in the primary outcome of death, stroke, MI, valve thrombosis, PE, or major bleeding. It was 18.4 versus 20.1%. There were numerically higher numbers of secondary endpoints, including death, stroke, heart attack, or systemic embolism in the apixaban group compared with the standard care group. Worse, in the subgroup of patients who did not have an oral anticoagulation, apixaban had an 86% higher rate of mortality. So, with those decidedly pessimistic priors, let's discuss the Envisage TAVI AFib trial, which compared edoxaban versus warfarin in post-TAVI patients who had AFib. About 1,400 patients randomized to edoxaban versus warfarin. The mean age, get this, 82 years. I love trials that enroll older patients. Half of the patients were women, too, in this trial. Edoxaban could be dose adjusted, and warfarin was targeted 2 to 3 INR, but could be adjusted 1.6 to 2.6 for patients older than 70. Antiplatelet drugs were allowed at the clinician's choice. 99+% of patients had AFib in this trial. The primary efficacy outcome was important in its breadth. Incidence of net clinical adverse events. Then this was defined as like basically anything bad that could happen. Death, MI, stroke, systemic embolism, valve thrombosis, or major bleeding. The endpoint was tested as a non-inferiority of edoxaban if the upper bound of the 95% confidence interval did not exceed 1.38. In other words, edoxaban could be 38% worse and still be non-inferior. The primary safety outcome was major bleeding. The primary efficacy outcome was tested first. And here was the result. The rate of the composite primary efficacy outcome was 17.3 per 100 patient years in the edoxaban group versus 16.5 per 100 person years in the warfarin group. Now, the point estimate of the hazard ratio was 1.05, so 5% worse. But you have to know what the upper bound is, right, to get to non-inferiority. Here, the 95% confidence interval went from 0.85 to 1.31. Since the upper bound of 1.31 was less than the non-inferior margin of 1.38, technically edoxaban met non-inferiority against warfarin. But rates of major bleeding were 9.7 per 100 person years versus 7.0 per 100 person years respectively. That hazard ratio was 1.40, a 40% increase in major bleeding with edoxaban. Now, what should we say about this? First, it's abundantly clear that rivaroxaban is inferior to warfarin in the bleeding endpoint. But what about efficacy? Well, the choices regarding non-inferiority in the first question are pretty debatable. 1.38 as a margin is pretty high. It's based on prior VKA studies that used only stroke or systemic embolism as an efficacy endpoint. But in this trial, the primary endpoint was like everything bad that can happen. In the prior trial, Atlantis, the non-inferiority margin was as low as 1.2, and if this were the case in Envisage TAVI, would not have met non-inferiority. A teaching point here, I think, is that non-inferiority trials are supposed to be used to test whether a new treatment is just as good because that new treatment has some other benefit, say better safety. Like the DOACs, they were tested for non-inferiority against warfarin for only efficacy, stroke, and systemic embolism. That is it. Then they did a superiority analysis for bleeding. In the case of Envisage TAVI, we have so many components of the endpoint they could be canceling each other out, which makes non-inferiority easier to reach. I think the message of Envisage TAVI is clearly that warfarin is the preferred anticoagulant in patients with AFib. And putting this message of all three trials together, it sure looks like DOACs are not the preferred agents. And I kind of like that what is new is not always better. We have to test things. Recall that patients who have TAVI are older. They often take antiplatelet combinations, and AS patients often have higher GI bleeding risk due to Van Willebrand's disease and/or AV malformations in the gut. So these patients are not like those in the clinical trials that studied DOACs versus warfarin. So that's it for this week, and you may have noticed that I did not get to the MasterDAP trial. I definitely underestimated how much study it would take to get a handle on post-BCI antiplatelet regimens, so stay tuned for that. I'll definitely get to that. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, friends, it really helps if you can give the podcast a rating. Write us a one-sentence review. That helps others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.